Hey, good morning, everyone. We're just going to go get going. I think a lot of people are late or stuck. The roads were actually fine. Some of the drivers weren't. So our first speaker today is Dr. John Mitchell, who's professor of surgery in the CT division. He holds the Patton Davis Chair. His hometown is actually Greeley, Colorado, and went to CU Boulder as an undergraduate, then to medical school at University of Michigan. And then he went to do his general surgery and thoracic fellowship at Massachusetts General Hospital, where I think my brother was a mid-level or intern on your service a couple of times, if I remember the story correctly. He was on active duty in the Navy for 4 years at Navy Medical Center in San Diego, and very briefly on faculty at Stanford before being recruited here in 2002 as the chief of thoracic surgery. He's really built the top thoracic surgery program in the country. He's led many things. I'll just name a few of them.
May I have your attention, please? This includes the testing of the fire alarm system.
May I
have your attention? May I have your attention, please?
3 times.
The testing of fire alarm system.
Is it safe? Okay. President of the Western Thoracic Association, director on the American Board of Surgery, director in the Society of Thoracic Surgeons. He's really one of the top clinicians in the world in the field of thoracic surgery. He's well published, over 130 publications. He's a great teacher, participated in many research projects and clinical trials. And he's really a seasoned and extremely accomplished leader. And I bet you we're going to get more than just a word from the American Board of Surgery. Who's supposed to be here?
So snowstorm, no coffee. We're going to just move on. So I'm going to talk about a few things about the American Board of Surgery. So here are my disclosures, and usually disclosures don't really mean anything, as most of you know, although I would point out in 2017, I was made a director of the American Board of Thoracic Surgery. And then a couple of years later, I was asked to be a director of the American Board of Surgery. At the ABTS and the ABS reciprocate individuals. And so I was the ABTS rep to the ABS. So the objectives today, you can see, just talk a little bit about the current structure of the ABS. There's been a reorganization that I'll briefly highlight, summarize the role of the ABS in your life currently, and talk about some of the current initiatives. So the first thing we're going to talk about is the current structure of the ABS. It's just something that you need to be familiar with, I think. So the American Board of Surgery was founded in 1937. It's a nonprofit organization. It provides board certification to individuals who have met a certain standard of training and education. It's one of 24 medical specialty boards that make up the ABMS. The ABS is in Philadelphia. It offers board certification in a variety of specialties, as you can see there, most prominently general surgery. Over the years, from 37 to past the turn of the century, it functioned fairly well. But when you got into the 20 teens, it became a little unwieldy. The number of directors was in the mid to high 30s. You'd sit in this huge room, nothing ever got done. And the idea about restructuring the ABS came to the forefront. So it was a 3-year endeavor. And at the end, they came out with a new governance structure that was completed in 2019. So it's kind of made up of 3 or really 4 parts. The first is the CEO and president. There used to be an executive director. Now there's a CEO and president. I'll show you her picture in a second. There's a much smaller board of directors that has a different function. They have the primary fiduciary interest in mind when they meet. They also provide overall guidance for the board as a whole. The main part of the board is now called the council. That's what the board was before, and now it's called the council. There are committees that will go over that do most of the work of the board. Entry into either the board of directors or the council is a competency-based nomination process. And I'll talk a little bit about that. And then finally, there are a number of specialty boards. So you have general surgery, you've got vascular, you've got critical care, trauma, burn, etc. Here's the structure in a nutshell. You can see the board of directors and the things they do. They're in charge of finance and overall governance, executive compensation. They can hire and fire the CEO. The CEO really runs the ship for the American Board of Surgery. And then the main thrust of the ABS lies in the council and the council committees. That's where most of the work is done. But there's also specialty boards that you can see listed there. And most of the counselors are also on a specialty board. So I'm on the complex surgical oncology board because it most closely fits what I do. But you can be on a specialty board and not be on the council. Here's the current leadership. Joe Beiske is the president and CEO. She and I were interns together and went through residency together. She's a very nice person. Ash Mansour is a vascular surgeon up in Michigan. He's the current chair of the board. As it turns out, he is the ABS rep to the ABTS. So he and I spend a fair amount of time together. And then Amy Goldberg is the incoming chair in July, and she's a dean at Temple. So a little bit about competency-based nominations. So to be on a board in the past, people would nominate you. There was usually several nominating societies that would put your name up if the ASA did that. And then 3 or 4 names would be put up, and then one would be selected. But now that still occurs. But now, in addition, you can nominate yourself. You can nominate one of your peers. And what the nominating committee does is they look at the overall structure of the board and the council, and they see what competencies, what skill sets are lacking. And they have us fill out a grid every year so they get a better handle of what things are missing, and then they'll pick somebody with that sort of competency need in mind. So if they want someone with, I don't know, educational assessment experience, or someone who's been a DIO at their institution, they can weed through the nominations and pick the people that best fit. But I would tell all of you, if you're interested in getting involved in the ABS, that it's a very worthwhile thing. It's been terrific. You can get involved by giving the oral exam and then move up from there. You can nominate yourself or have a peer nominate you, or society. And I would encourage everyone to think about that. Here's the board of directors, 13 people, most of which came from the council. Here is the council, 30, 35 members at any one time, a bunch of committees, competency-based open nomination process. Here are the committees of the council. So you can see that, just as you would guess, assessment, education, DEI, research. I'm actually on the Diplomates and Surgeons in Practice Committee. That does 2 things. That deals with all the disciplinary issues. So twice a year, I sit in a room and go over 25 cases of ne'er-do-wells with ABS certificates that have done something bad. And the question is, should their certificate be revoked? Most of the time, it has to do with DUIs or malpractice issues, but sometimes the stories can be pretty spectacular. Here are the specialty boards. So top left there is general surgery, vascular. Here we are down here, Surg-Onc is here, pediatric, etc. So the specialty boards are responsible for their own exam development and delivery. So the qualifying exam, the certifying exam, and the continuous certification exam, all done by the specialty boards. All right, I'm going to talk just for a second about EPAs. I refuse to answer any complaints about them, though, so don't think about complaining. And almost everybody in the room knows more about EPAs than I do. I don't fill them out. I've heard a lot about them, though. The EPA stands for Entrustable Professional Activity. It's a unit of work that the physician, the trainer or trainee does and can be observed. It's a unit of work, of clinical work, and it allows for an assessment of the mastery of that clinical work or entity. So it is not the same as a competency. It's not the same as a milestone. There are 18 general surgery EPAs. I'm sure many of you are very familiar with it by now. And if you think about it, the core faculty are charged with getting the residents ready for independent, autonomous work out in the real world. And we use a lot of surrogates, right? Case logs and program director assessments and test scores, but EPAs can actually better define if someone is really ready to be autonomous in that activity. Okay, so they're not competencies, they're not milestones, they're complementary to those assessments. Here's the timeline for EPAs, and you can see by 2015 or so, the board became very interested in competency-based medical education. They developed an initial 5 EPAs. There was a trial, a pilot program. It was very successful. And now in July of 2023, the EPAs have been rolled out. Here are the 18 general surgery EPAs. You can't have an EPA for every single thing. So a lot of decision-making went into the 18 here. And I thought you'd be interested in this. These are numbers from July 1st, and you can see that over 63,000 assessments have already been done. And the penetrance of the use of EPAs in ACGME general surgery programs is quite high, 324 out of 359, so 85%. And you can see all the number of total users. So people have really dived in. In this first year, the emphasis is just progressive engagement. That is by far the most important thing. The ABS runs courses for new writing facilitators. There's vascular surgery is going to get their EPAs off the ground in 2024, this July. And in 2025, trauma, burn, and critical care and surg-onc are as well. So in addition, a lot of work is being done behind the scenes regarding competency-based medical education with many of the stakeholders in the world of surgery. All right, there are the deadlines, and you can see the number of EPAs, like in pediatric surgery, 20 EPAs coming down the pike. Feel free to go on the website and learn more about EPAs should you desire, but I think they're here to stay, and competency-based assessment is as well. All right, a word about the exams. So there's 2 exams to become certified, a qualifying exam, which is the written exam, and a certifying exam, which is the oral exam. Usually you take the written one first, and then you have the oral. The written is given in July. I think everybody knows that. And then the orals are given twice a year in October and March. There are a bunch of requirements that you should talk to Dr. Naylor about to make sure you're all squared away by the time that you finish. I won't go through them all. You need to have a license. You need to have documentation that's done up front. This is really important. So if you have a international rotation, if you have an extension of your training, anything like that, that has to be approved by the board in advance. And you need to have it in writing, and it needs to be submitted when you apply for your qualifying exam. How do people do? They do really well. So if you look, the qualifying exam is on the left. Look at the blue bars. That's the pass rates for first-time individuals. And I'm sure all of the Colorado residents will pass on the first time. The pass rate's 95 to 97% for the written exam. It's very high. For the people who do fail, the green bars are for everybody. So understandably, it's a little bit less. And then for the oral or certifying exam, the pass rates are 80 to 85%, also very good. Now, one of the things that came up in the pandemic is that we used to meet and do this live, in hotel rooms. There are a number of problems with that, but with COVID, that totally went away. And now we do virtual exams. And I would tell you, I think for the foreseeable future, virtual oral exams, at least for the ABS, are here to stay. And for people that worry about, does that detract from how you would do? The answer seems to be no. The top graph shows live exams in person. Bottom graph shows the virtual exams, and you can see that the outcomes are essentially identical. So people do very well with the virtual exams. They're very popular with the trainees because they don't have to travel anywhere. They can stay at home. And I would tell you the platform that we use for the virtual exams works very well. So say you've graduated, you've become board certified, you should be all set, but the answer is no. You need to embark on lifelong learning and training, or MOC, maintenance of certification. It used to be that when we graduated and started, we would have to deal with maintenance of certification every 10 years. So you might interact with the board 2 or 3 more times your entire career. But now, the continuous certification, you need to do this every other year. And some of this is mandated by the ABMS. They wanted a tighter window or interval on the continuing certification programs for all of the specialties. Okay, so the need for it is obvious, I think. Starting in 2018, they went to this every other year program. And when you get board certified, you will be automatically enrolled in it. What do you need to do? You're board certified, 2 years are up. You need a license. You need hospital privileges. You used to need references, but I'll get to that. You don't anymore. You need to do a quality improvement project. You need to have CME. Once you get credit after you take your first CCA test for the CME that's generated in doing the test. All right. And then you take the test every other year. So every ABS specialty board has a CCA assessment. So surgeon, vascular, everybody has one. There are 40 questions. For general surgery, you do 20 questions that are a core of general surgery and 20 questions that could either be breast, abdomen, GI tract, or comprehensive general surgery. The reason it's every other year is if you're double boarded, you can do general surgery 1 year and you can do vascular on your off year. Okay. The questions are very straightforward. They're open book. They're untimed. There are references there that are given to you at the end. How you could not pass this, I don't know, but almost everybody passes it. Okay. That's the bottom line. It's taken at home online. Once you start it, there's a window of about 3 or 4 months, but once you start it, you have 10 days to finish your 40 questions. Okay, 2 weeks, 2 weeks to get it done. Yeah. And you got to get a total score of 80%. It's open book. You can't fail. One of the things that the board did was one of the onerous things about MOC was getting your case logs and submitting them. And we found out in the last year or two, nothing is done with that other than some research. So we got rid of it. It was an extremely onerous thing. There's a new code of ethics and professionalism. So when you take your recertifying test, you will attest to a bunch of things that say you adhere to the code of ethics. One of those is self-reporting. So if you run afoul of your state medical board, you need to report that to the board. That's extremely important. Instead of reference letters, which were also onerous to get, Dr. Schulich would fill out 900 of them every year. You just have to list 2 people when you take the CCA, much simpler. So over 11,000 CCA tests were given in 2023. You can see the numbers there. All of the references now are going to be given to you. You can't go wrong. It's not that hard. Here's the timeline for this year. August is when it opens. November is when it closes. Okay. You gotta register in early August, and then in August, you start August 26th. You have 2 weeks. Not hard. And then finally, I just touch on a couple of other ABS initiatives, all designed to make the diplomat's life better. One is the reporting of CME. So it used to be that you would get all your CME from all the conferences you went to and collect them all and then manually upload them, every 5 or 10 years. And it was really, you'd lose a bunch. It was kind of a ridiculous process. Now, CME is uploaded directly from the conference you go to. When you sign up for a conference, you check a little box that say, hey, it's okay to share my stuff with the AC, the Accreditation Council for CME. It goes to them. It gets uploaded to the ABS automatically. It works very well. And that's going to be the wave of the future. So you do not have to fill out all your CME. And you can see since July of last year, over 1 million credits have been uploaded. Okay, 28,000 activities and 21,000 learners. So it works. I've even seen it uploaded in my instance. The other thing I just want to touch on for a second is focus practice designation. So this is not a certification, but the ABS in specific instances will award this designation in subjects where surgeons might have a focused concentration of the practice. So if you're a general surgeon, but you mostly do bariatrics, you can get a focused practice designation in bariatric surgery. You have to demonstrate that you do a lot of it. You have to take a test, things like that, but you can get the designation. The bariatric surgery was the first one that was done. Now there's going to be an adult complex thyroid and parathyroid surgery, FPD, as well. The politics behind doing this are considerable because in this case, for the thyroid surgery, you had to get the head and neck people, surg-onc people, general surgery people all in one room and decide on caseloads and parameters to do this. There was an effort to try to get a breast surgery FPD that ultimately failed because of the difficulties in getting everybody on the same page. There have been efforts in foregut surgery, liver surgery, things like that. But I'm not sure how many more FPDs are going to come down the pike because of some of these issues. And that's it. That's all I got. Happy to answer any questions. Yeah, there are writing committees for both the CCA and for the qualifying exam, and they are populated by individuals not on the board, not on the council. You can be, but typically are not. And it's another good entry point to get involved in the board. So it's and that occurs across all of the specialties. The oral examination, those are recycled to some degree. They're benchmarked every 5 or 6 years, meaning they're reassessed. We are always crafting and changing and updating them. So there's a bank.
John, great overview. Thank you. We're obviously a very technically surgeons are people who operate. So any thought about including a competency basis for surgeons in practice based on their current skills, given the fact that simulation, et cetera, can be done, and you could actually ensure that somebody has at least basic skills to do the operations they say they can do?
Yeah, that's a great question. So, simulation is another competency-based assessment that can be done during training. People have explored, or boards have explored, the use of video-based assessment. There was a pilot within the ABS that's kind of died down a little bit, but there is a similar effort within the American Board of Thoracic Surgery. There's a pilot underway to do video assessment of technical skills prior to graduation. You can imagine it's somewhat complex. The type of surgery heavily influences that assessment. So if you're doing a robotic, colon resection, it's a lot easier to assess that compared with an open operation, a cabbage potentially, where it's very hard to make those judgments. All right.
It's nice that in the Department of Surgery we have a bunch of leaders like Dr. Mitchell who help guide the process of examination and can answer questions about the process. So thank you, John.